It is my pleasure tonight to introduce our speaker, Dr. Kapadia. He's with James River Cardiology. He received his medical degree from UVA, a residency in internal medicine at MCV, fellowship in cardiology from Brown University at Rhode Island Hospital. He is board certified by the American Board of Cardiovascular Disease. He is in practice with James River Cardiologist at the Ashcake Medical Center just off of Hall Street over near Wood Lake. And I'm very happy and glad to say that he is a good friend of mine. And when I say that, I don't mean that we are friends that go out and socialize together, but I have been seeing him for quite a few years as my cardiologist, and I think he's a great doctor and a good man. So it's my pleasure to introduce Dr. Kapadia.
Thank you, guys. I'm excited to, many of you guys know me, and thank you, Christy Combs, who presented, shared with you some of the material, just some information, key numbers to note. And what I'm going to talk about today is kind of maybe busting some myths, kind of sharing new information, thinking about cardiovascular disease through a different lens. And that lens is the lens of longevity, but also health span. And so we all think about longevity as how long we're going to live, right? And is that the best metric for any kind of disease state or condition? Do you want to live till you're 130 or 100 if you don't have good quality of life, right? That's ultimately what's really, really important. It's not how many years you're on Earth, but it's really what are the best quality years you have on Earth. And at least I think so. And so health span kind of speaks to that idea, that how can we lead a healthy life until we can't anymore. And so we're going to talk about cardiovascular disease, hone in on how we detect it, how we measure it, and talk about the situation with cardiovascular disease, because it's one of those things where I feel like there's a lot we can do to eliminate the disease or really mitigate it and decrease. And hopefully folks of you that are with me as patients kind of get the sense that that's how I practice medicine is. We can't fix everything, but we can slow some things down, and we can turn around other things, and still try to, my number one priority is maximizing quality of life, right? Doing things you're doing. You guys know this guy? One of the best Meet the Press hosts, Tim Russert. And so he passed away in the NBC studios, 20 plus years ago. And he had heart disease, believe it or not. He was overweight, had high blood pressure, had a calcium score, we'll talk about that showed plaque in his arteries, a CT heart scan, and had a normal stress test a couple of months prior to his heart attack. His fasting blood sugar was 104, so some of you will recognize that as pre-diabetes. And then he was on medication to lower his cholesterol, and you'll start to see these terms LDL, triglycerides, if you don't know them already. I'm sure you do. And people thought, okay, well, he seems pretty good. Why would he suddenly have a heart attack and die? So that's kind of how we frame the conversation. And in the United States today, we've done a lot of things to save lives. People have heart attacks and strokes, and yet it's still the number one killer of men and women, equal opportunity offender in the United States, heart disease, right? When we talk about heart disease, we talk about mostly heart attacks, and we talk about heart failure, things like that. And cancer is still a significant cause of morbidity and mortality, but heart disease, at least in 2021 and even today, drives a lot of morbidity and mortality. The challenge is we have the most expensive healthcare system in the world, and so we think we should have the best quality healthcare. But if you look on multiple metrics, infant mortality, maternal mortality, we rank really low, like 35 in, right next to Costa Rica. And if you look at our life expectancy, which has been growing, if you look at the black curve, that's the United States, in the last couple of years, it's taken a dip down, while other industrialized countries, Western and Asian, have continued to go up. Why is that? What's wrong? And that's a whole nother conversation. But what I wanted to kind of frame here is that when you think about heart disease and heart attacks, you start to see the dark blue, or the dark bar is men, and then women, and is lower. So from the 40s to the 60s, men have a higher incidence of heart disease and dying from heart-related events, and the curves start to switch with women later on in life. But there's a sweet spot here in the 60s, in the 50s and 60s, believe it or not, where the amount of people dying from heart disease is actually in middle age. And the challenge is, and the irony is that we're only starting to do early detection prevention at the very same time that people are dying suddenly. So something's wrong with that, right? So it seems like we need to start this process of detection and prevention a lot sooner, because people die suddenly from sudden cardiac death. And so the sudden death, that means dying suddenly, collapsing at home, somewhere in the mall, it can often be the first sign in 50% of cardiovascular patients, right? You have no symptoms and suddenly you're down, and then you're gone. And that can be, obviously, it's very tragic for everyone involved, particularly the people that are left behind. And so how can we do better around this situation? So we need to shift our paradigm of how we think about healthcare. Today, it's sort of very reactive. If I have a problem, I'm going to run to the hospital, the ER, wait till it's broke. It's often very cookbook medicine, right? Everyone gets treated the same way, one size fits all. If a big research trial says, hey, you need to take a statin, or you need to take Jardiance, everyone gets it, and it's part of the guidelines, right? So it's a cookbook. And then it's been historically very patriarchal. What do I mean by that? When you're in the doctor's office, the doctor is sitting, you're sitting, but it's sort of like, do what I say, and otherwise, why are you here? And that's shifting, that patriarchal kind of mindset to the 5 Ps I have on the far right, which is going from reactive to proactive, then preventative, personalized, meaning let me take you with all your things that we're measuring and be personalized about our approach to managing your care, and do it very precisely, right? Are there things that we can measure, targets that we can measure that tell us, hey, this treatment is effective and needs to be continued? And then how can we create a different sort of culture around care where it's participatory? We do a lot of what we call shared decision making. So it's not me telling you what to do, but presenting you with information, and then us making the decision together, right? And I often present that to my patients. And I see a lot of folks that want to take a lot of supplements, or they're seeing a integrative functional provider, and this is all good, and they don't want to take a certain drug that I offer or recommend. And so we chat about it, and we chat about the pros and cons. But at the end of the day, if the patient doesn't want to do it, I still support them. Just my job is to educate and coach, and then follow them along, right? So that's the 5 Ps, and it's sort of the lens from which I practice today. And in the United States, believe it or not, there are a handful of genetic diseases. Very few that are single gene diseases that now we have the ability, like sickle cell anemia, to change the gene through CRISPR technology and cure the condition. But most conditions are polygenic. There's multiple genes. They might be inherited, but there's a nature-nurture aspect to it, right? So you might be born with some tendency to have a problem, but it gets expressed based on diet and lifestyle. And so if you look at 15 chronic conditions, and they're all kind of listed, if you can see, diabetes all the way to asthma, airway disease, chronic kidney disease, congestive heart failure. they're really driven by their 8 risks and behaviors. You know, poor diet, sedentary lifestyle, smoking, too much alcohol, not enough sleep, not enough access to care, poor standard of care, stress, and lack of health screening. So, and smoking, which fortunately is decreasing in terms of cigarette smoking, but alarmingly, vaping is going up in our younger people. So that's a challenge. So all these risks and behaviors can hyper manifest these conditions or even cause them that account for 80% of all total costs for these chronic diseases. So if we try to fix and mitigate some of these behaviors and risks, we could really save a lot of money. I started the talk talking a little bit about health span versus lifespan. So if you see the curve, this is the average population is black, and you know, at some point you start to have your peak in your 40s, and then blood pressure, diabetes, arthritis happens, and then you suddenly you go down this path, and it's a slow, painful death. You know, we have all these chronic conditions that you can call slow suicide in some ways, but it is a feature of the choices that we make a lot of times. Versus thinking about how do I change that curve so that we all know we have to leave this earth someday, but if we could stay healthy for as long as we can and then fall off the cliff, right, later on in life, that would be great. And if we could all just pass away in our sleep, that would be the ideal. But we can't always choose those terms. But that delta, that space between the two curves is kind of a measure of increased or enhanced health span, right? It's shifting the curve up and down. So there's a guy that I follow. He's a physician in Austin, Texas. He does wellness medicine. He serves a very small percentage of people that can afford to pay his prices, but his knowledge is really good. And he has a book that talked about this called Outlive that was a New York Times bestseller, and he has a podcast called The Drive, which I do follow. So I learned a lot just from his deep dive. And so it's a really good book. It's a worthwhile read if you haven't read it. I think this is kind of saying the same thing, and these are all the different conditions that then lead to heart disease, right? I don't need to repeat them since we just talked about it. And when we talk about heart disease tonight, I'm going to specifically be talking about ASCVD, atherosclerotic cardiovascular disease. That's where plaque builds up in blood vessels and causes heart attacks, blockages that require stents or bypass surgery, or can cause stroke, or can cause peripheral arterial disease, blockages in the arteries that feed the legs. So if you think of our hundreds of thousands of miles of arteries in our body, all of them have a Teflon lining, and so nothing should stick to them. But something happens in early life, in our 20s and 30s typically, that causes injury to that lining called the endothelium. And once that lining, so you need 3 things to happen to develop plaque: injury to the lining or the endothelium, elevated cholesterol particles, and then inflammation. And when that happens, cholesterol gets plugged into the lining of the arteries, and this graphic kind of shows a normal blood vessel starting with little fatty streaks, and then gradually more and more plaque in the artery that causes narrowing within the artery that can restrict blood flow, or that plaque sometimes can rupture, exposing the cholesterol that's in it to the flowing blood, and that creates an injury response that can result in a heart attack situation. So you could have a 50% blockage with soft, vulnerable plaque that suddenly gets ruptured, and you have a heart attack, and you can go from a nothing plaque to 100% plaque in a matter of seconds and minutes, and that's a heart attack that requires going to the cath lab, getting a stent, that type of thing. So we have life-saving measures that has really changed, you know, the outcome from people that have heart attacks. But it can also cause narrowing gradually that causes shortness of breath and chest pain, and then that requires, you know, a stent or a bypass to fix that blood flow. So this is a process that goes at ebbs and flows over decades, starting in our 20s and 30s, and then manifesting oftentimes in our 50s and 60s as a cardiovascular event. So this we want to try to prevent if we can. And we'll get into that. So how do we detect this plaque at its earliest stage? Some of you may have heard of calcium scores or CT heart scans. So this is a really nice way to look for plaque in blood vessels using a CT scan or an X-ray. And this requires very little radiation. There's no IV, no dye. It's very fast and costs about $100 and change here in the Richmond area. So as this plaque that you saw earlier, as it matures, by the time we hit our 50s and 60s, that soft plaque calcifies as it heals and matures. And that's why you can see it on an X-ray, particularly a CT scan. So this has been an amazing tool in our toolbox to diagnose heart disease at a very early stage. And so I tell patients it's like a mammogram for the heart, but even better, because it detects the disease. You know, you don't have to do a biopsy. You know it's there. So your score could be 0, which means you've got no calcified plaque, or it could be a non-zero number, and that number could be anywhere from 1 to several thousand, believe it or not. So the higher the score, the more plaque. And what you can see in the CT scan is, first picture has no calcium, but this white stuff right here is calcium in the left coronary artery. So that person would have a score of, let's say 500. And just because you've got plaque in the artery doesn't mean you have a severe blockage. It just means you have plaque in the artery wall. And then there's more tests to do to figure out, is there a critical blockage or not? But this is the first step. And you can go one step beyond that and actually use a faster CT scanner, inject dye in the vein, and then take pictures of the arteries. And this actually is like an angiogram or a heart catheterization, if some of you had that can look at the arteries. So it's non-invasive, it requires dyes and more radiation, but it's a really good way to take one extra step to look for the arteries, to look for soft plaque, and to see the calcium that's there. So, and the degree of blockage if there is one. So there are a lot of places in town that do that. And then the next step is to do actually a heart catheterization, where we go through the wrist artery, sometimes the groin artery. We do that here on the 3rd floor, and some sedation. And as you can see in the middle here, this is the right coronary artery. This is the catheter. Here's the dye going in, and there's a severe blockage right in the middle of the right coronary artery that's like 90%. And that's something then we could go in with a wire and a balloon and stent it and open it up and restore normal flow. So that's a heart catheterization. So you can see the progression. What's another tool that, this is what we do at James River in our offices, is it's a stress test. It's a nuclear stress test. And some of you may have had them. This is the newest version of that, called a PET scan, PET. And you may have heard of PET in cancer detection. Well, this is PET in terms of looking at blood flow in the heart. So it's a really good way, non-invasively, to look at blood flow. The other tests that I showed were anatomic tests. These are physiologic tests to look at flow in the artery. So in the top box is flow during stress, and the bottom is at rest. And what you might be able to see from where you are is, I think about this as donuts and horseshoes. Okay, so the top are donuts and the bottom are horseshoes. And there is decreased filling in this tail of the horseshoe during stress that fills out nicely, during rest. And you see it in multiple views here, and you can see it over here. And this all corresponds to the same artery. And so this tells me that there's a blockage in one of the arteries on the left side of the heart. So based on this information, the next step would be to go and do that angiogram that we talked about, with the idea that if there's a blockage severe blockage, that we could fix it with a stent or a balloon. So this is cardiac PET. We do it in our office. It takes 30 minutes. It actually has less radiation than a conventional SPECT, or the regular nuclear stress test. And it's faster and more accurate. So we have 2 offices, and hopefully a third that'll do that. So that's the imaging side. The imaging side. Now, what about blood tests? How can we detect risk for heart disease in blood tests. So before I jump into the cholesterol piece, you know, the blood test that we have, if you go to the emergency room, if you have chest pain, there's a test called troponin, and it's an enzyme released by the heart muscle in response to stress. If you have decreased blood flow, if you're having a heart attack, that troponin will be elevated, and it can detect very, very low levels of that. So that's a good tool in the acute setting, the ER setting, if someone comes in with chest pain, to see if this is a heart situation or not. Sometimes there can be false positives, but it's a very good marker. And there's another marker called NT-proBNP. So if you present with shortness of breath, that marker might be up, and that could be an indicator of stress on the heart or heart failure. So those are two important tools. I won't go too much into that today beyond that, because I really wanted to focus on sort of the upstream early detection, and that's in cholesterol. And, you know, many of us think that cholesterol is a bad word, right? That we shouldn't eat cholesterol, cholesterol is bad. But listen, we can't live without cholesterol. It is one of those molecules of life, and it is in our cell membranes. It's in various hormones and bile acids, vitamin D, sex hormones. In fact, only about 15–20% of cholesterol hangs out in the blood. The rest of it is in these other places. And we make most of our cholesterols ourselves. The liver makes the most, but every cell, including the brain, makes cholesterol. We get some from the diet, but dietary cholesterol doesn't equate to cholesterol in the blood. Let me just say that again. Dietary cholesterol does not cause elevated blood cholesterol. There's other stuff, and we'll talk about that. So when they say eggs have too much cholesterol or seafood has too much cholesterol, yes, that's true, but that does not contribute to your elevated cholesterol. There's no such thing as good and bad cholesterol technically, and I'll explain why in a little bit. Because cholesterol is cholesterol, and it's just how it's packaged. And so cholesterol and triglycerides, which is the other marker, and on the paper there's some important, the sheet that you have, that are key things to know when you talk to your doctor. So triglycerides are a marker of carbohydrate sensitivity. So when you eat a lot of carbs, if you have diabetes or prediabetes, oftentimes your triglycerides are going to be high. And that's probably the most important thing when you're doing your cholesterol test. Why do we do it fasting? For two reasons. Because triglycerides respond to what you just ate, and so does blood sugar. So that's why the fasting part. It doesn't really affect the LDL cholesterol or the HDL cholesterol very much. So cholesterol and triglycerides can't float freely in the blood. It's like oil and water. So the liver packages up in these protein particles called lipoproteins, and it shuttles them there. You can think about them as transport vehicles. So the liver transports them to various organs, and each cholesterol particle has varying amounts of cholesterol and triglycerides, and they're different sizes and densities, and so we have names for all that. So here are some key cholesterol numbers to know, and I'm going to show you some other pictures. ApoB. So ApoB, or apolipoprotein B, is probably the most important number. Most docs in town don't even look at it, but the Europeans and the Canadians do. Go Canada. We all measure LDL cholesterol, and that's not a bad tool, but it's just know that it's calculated and not often measured. And so LDL cholesterol, while it's a good number, can be fraught with challenges, particularly when the triglycerides are elevated, and I'll show you some examples of that. So ApoB is a really good marker because it measures all the bad cholesterol particles in the blood, and it's a measured particle. There's another number called non-HDL cholesterol. So if you take the total cholesterol in your profile and minus the HDL, the quote-unquote good cholesterol, you're left with a non-HDL. That's not a bad number too. And then finally, there's a genetic marker called Lp(a). Just hold that thought. I'll get into that in a little bit because it's an important accelerator of ASCVD, or plaque buildup. So this is just a picture showing all the various kinds of lipoproteins, from ranging it from size to density. So the larger ones are to the right, and the more dense ones are going down. So density means like, how much mass it has. So the chylomicrons all the way down to the HDL and everything else between. So just know that there's a family of these lipoproteins. I don't expect you guys to remember all the details here, but just know there's a lot of stuff. And the ApoB is critical here. So when you look at your cholesterol panel, you sometimes might see VLDL reported out. And that's very low density lipoprotein. LDL stands for low density lipoprotein, and then IDL is intermediate density lipoprotein. So each of these particles are tagged with one ApoB molecule. And the important thing is here, what determines what kind is how much cholesterol and triglycerides in any given particle. But when you measure ApoB, you're measuring all these sort of what we call atherogenic lipoproteins, meaning lipoproteins that are likely to cause plaque in the blood vessels. That's the meaning of atherogenic. So here's one where if you just solely looked at LDL concentration on your cholesterol profile, and if two patients both had a cholesterol profile which showed an LDL of 100 milligram per deciliters, are they the same people, right? So what is really important is looking at the size and the density of these particles. So someone that has, say, diabetes or prediabetes would tend to have a lot of small particles. And someone without diabetes would have larger particles. Each of these patients have the exact same concentration of cholesterol in the blood if you were to measure. That's what this does. But in each particle here, the guy on the right has a lot more small particles. Well, what we know is that small particles cause a lot of mischief. And so if you're big and fluffy, your particles are big, that's great. If they're small, they can get into the lining of the artery and get oxidized and inflamed. So if you just think intuitively, small is bad. And so unless you start to measure other parameters in your cholesterol profile, you might be fooled to think, oh, my LDL is 100, I'm in good shape. But actually you're at high risk if you haven't considered some of the other aspects. And that's where I do a more deeper cholesterol profile. So you get the typical lipid panel, which most docs do today, but then I get a one called NMR, and it has all the particle numbers and particle sizes on there, so it kind of is more spread out. And I find that to be a very valuable tool. Can you figure it out from the lipid profile? You can sometimes if you look at the triglycerides and they're high, then that might give you a clue. But this is a really helpful tool. It's called NMR. So if your doctor doesn't do that, ask them about NMR and ApoB. And there's one more at the end that I'll tell you to get checked out. So here's an example of a typical cholesterol profile with LDLs 100, but the triglycerides here are 168. If you see that, and you might say, oh, this thing says, optimal range less than 150. I'm 168. That's not too bad. But actually, that's a clue that this person might be insulin resistant or pre-diabetic. So if you did an advanced panel and with the NMR and all that stuff in red, we know red is bad. So this person's ApoB and LDL particle number, they have a lot more particles. They're smaller particles. And so you get a lot more information, and this patient has higher risk. It doesn't mean more medicine necessarily. It could be tighter control of their diet and exercise. I'm going to skip this slide. So when I think of what's the most important numbers in your panel, ApoB, then non-HDL, then LDL-C in terms of predictive value and what drives my decisions in terms of management. There's a condition called familial hypercholesterolemia. So remember we talked about genetic conditions. There's a few genetic conditions, and this is one where there's a mutation in a gene that causes very high cholesterol early in life and is associated with early onset heart disease. And there's two versions where you have two genes where your LDL cholesterol, your bad cholesterol, can be greater than 300, or you could have the other kind, which is more common, where your LDL is around 180 to 200. And both of these are associated with early onset, heart disease, and so need early identification and treatment. I don't know if you know this guy. This guy was the trainer in Biggest Loser, Bob Harper. Very healthy guy, trainer, and he had a heart attack, sudden cardiac arrest too, got resuscitated, and he had that condition, a genetic condition. So despite his best efforts, this thing played out. So he's been, a big spokesperson, for heart health. We talked a little bit about earlier, mentioned a term called Lp(a). So there is a genetic marker, an abnormal protein, I call it a mutant lipoprotein called Lp(a) or lipoprotein(a). What happens is that there's another lipoprotein called apo(a), and it gets bound to this ApoB, which is a normal particle, and makes it much more sticky and more prone to cause plaque. And so it's something that I've been testing for decades, but now in the next year or two, we have some really good treatments to obliterate Lp(a), and the science is really cool. So Lp(a), 20% of the population in the United States has it, highest incidence in African ancestry, then South Asians, and then everyone else. So it's an independent ASCVD factor. It increases inflammation, clotting tendency, plaque buildup. So I check it once in every patient that I see, because it really helps me drive down, and sometimes it helps me, what are my goals? How I might need to be more aggressive about driving their cholesterol down. In a year or two, we'll have drugs to knock this out completely. What other things should we measure, and should your doctor measure? So inflammation, I started, is part of the triad that causes plaque in the arteries. And so measuring C-reactive protein, myeloperoxidase, Lp(a)2, these are some numbers that measure inflammation in your body, either throughout the body or specific to the blood vessel, and it can be helpful. Knowing your A1C, whether you have prediabetes or diabetes, is really helpful, because that's also a risk enhancer. There's an amino acid called homocysteine that's not very common, but some people can't clear it out of their system very well. And that can also drive risk. And then gout, elevated uric acid is also another feature that drives inflammation and cardiovascular disease. So I tend to check a lot of these things in patients that I see. We talked about diabetes a little bit, or, so what is that? So there's a whole spectrum. I find it interesting. It's way better now, but a lot of the patients that I would see would have their sugars hovering in the 100, 110, 120 range. And I said, hey, is your primary care doing anything about it? No, they're wait until I get diabetes. And so my thought about that is, once you get diabetes, you've lost 80% of your pancreas's ability to generate insulin. And so why get to that point when this concept of insulin resistance starts decades earlier? And so the problem is that we live in a world where we're overnourished, we have too many carbs, we have a lot of stress, and so this creates inflammation, and our body's ability to transport glucose or sugar back into the cells becomes impaired, and that's a condition called insulin resistance. So high levels of insulin produced by the pancreas are in the blood, and that creates high blood pressure, accelerated plaque buildup, and then eventually the pancreas tires out, you can't produce enough insulin, so then diabetes happens and the sugar starts to rise. So this is something that we can combat very early with diet and lifestyle measures. Prevalent here, right? I won't spend too much time here, but 1 in 10 in the United States has diabetes, and even a larger proportion has prediabetes. And if we look at, probably 70% of the U.S. is overweight or obese, and so a good number of them have insulin resistance. So there's a lot of opportunity to fix these problems. I'm not going to get too in the definitions here, but just knowing that there's different categories. But the problem is, regardless if you're pre-diabetic or diabetic, you're at risk. So treat early. Again, it doesn't mean medications. A lot of it's diet and lifestyle. So the pillars of longevity are really around, okay, so we have all this background of cardiovascular disease, but regardless of the disease process, we know that eating well, sleeping well, sleep's been underrated for many years. We used to tough it out, even in residency. You don't need much sleep. You can tough it out, be on call. We know sleep is really important, probably the most important thing. We can't do without sleep. Your physician your well-being, right? Your mindset, stress, and then exercise. Not necessarily in this order, but they're all very, very important. We are overnourished. So the problem is we have abundance of food. So how do I think about food interventions? And there's three ways to really think about these food tactics. One is you can restrict the kinds of food that you eat, right? Less carbs, less fat, less this or that, and the keto diet is an example of that. Or you can restrict your time of eating, right? So many of us are eating from the moment we get up to the time we go to bed. What if we restricted that from, say, 12 to 6, noon to 6, and that's the term intermittent fasting, right, that people talk about that. So not eating after 6 p.m. and then eating again at 11 or noon and starting that with a high protein, a protein-rich diet. That can translate into weight loss and improve insulin sensitivity in some people. And then just cutting back the amount of calories that we eat. So that's another tactic. You could say, okay, I'm just going to reduce calories across. Whether I'm eating breakfast, lunch, and dinner, I'm just going to eat less. And that also translates into better outcomes. So if I characterize this as food tactics, the first order of business, the first thing is to consume less calories. Or we just consume too many calories because we're not hunter-gatherers anymore, where we have to go and find our food. Food isn't scarce. It's in our faces day and night. And so we just need to consume less calories. And our bodies have not evolved from our hunter-gatherer days to deal with the scarcity, to deal with the abundance of food. And so what we do is we store it. And we store it here, we store it here, but really storing it here is really where it's bad, in the midsection. And that creates inflammation overall. Cut the junk, so less processed food, less packaged food, less stuff in the middle part of the grocery store, eating more fresh food on the side, on the aisles, and getting more protein. And that's something that's kind of raising awareness. Protein, we need protein. We're losing muscle mass as we get older. We don't consume enough protein, and it's also very satiating, right? It makes us full faster. What else can we do? We can use a continuous glucose monitor, those little patches you see people swipe, and typically reserved for patients with diabetes, but you can buy them off, online now. They're not cheap, but it's a really good way to assess your response to the different foods you eat, and we would be surprised. And you need to just use it for a month or two and record what happens to your sugar when you eat something where you think, oh, this is not a bad thing, and suddenly you see your glucose spike. So the CGM is a really good tool to get these kinds of inputs, and it may change the way we decide to eat. And then drinking less alcohol. We got the Surgeon General's thing, was it last summer, that I gave a talk recently. I was asked to do a talk at a place where my mom lives, and they had a wine club, and they were determined that I should do a talk about heart-healthy wines. And unfortunately, there isn't that thing. Even the red wine thing is a myth. There's not enough flavonoids. Alcohol is alcohol. Your body doesn't know how to process it. And the way I framed it is that in Europe, the way alcohol was treated, and wine drinking in particular, was that it was a social glue, right? It brought people together. You had long meals, and you would drink some alcohol. So I don't think the alcohol necessarily was the health-inspiring thing, but it was really the sense of community and connection that was positive. But if you're drinking by yourself in a bar at night, that's probably not, even if it's red wine, it's probably not healthy. So if you're drinking it, drink it for social reasons. You like the taste of it. Just don't drink a lot. But there is no health benefit to it. So we talked about, sleep is a big pillar. Getting at least 7.5 to 8 hours of sleep a night is important. We have 90-minute cycles of sleep. and you have to kind of go through those 90 minutes to get the REM sleep into the deep sleep and then back out again. And so it's really important from a restorative perspective. And if you don't get enough sleep, you start to get inflammation, you can get fluid retention. Sleep apnea is a good example of someone that gets poor quality sleep for different reasons, but they're not getting good quality sleep. So they get very tired, they get headaches. So sleep is really, really important. There's a whole lecture on tactics for sleep, but that's beyond what I can do today. And then stress, anxiety, depression, loneliness, all these things are really important drivers of all diseases, cardiovascular disease per se. So being mindful of that and having connection is really important. I like this. I borrowed this slide from years ago for another talk. What fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day? So exercise is really, really important. And I think it's probably, exercise, nutrition, super important. And I've always exercised most of my life, adult life, but I think I've taken it even more seriously in the past few years. So I think of exercise as, the components are stability, so that you're stable, that you don't fall, you have good core strength. That's really important because we don't want to get fall. We don't want to fall as we get older. Strength, your muscle, you start to lose muscle mass. So having strength to do the things that we like to do, open a jar, lift your grandchild up, get up from the carpet, the floor, up, all those functional things start to degenerate as we get older, and if we don't do something and invest in it now, that goes away. Your cardiac output, at the aerobic efficiency. So there's different forms of exercise. And we know that exercise is good, right? That the American Heart Association recommends 150 minutes a week of cardio, moderate to intense cardio activity. And so the more exercise you do for longer, the less chance you have of dying. And you don't have to do very much. A little bit off the couch goes a long way, right? And we know that sitting is the new smoking. So we kind of sit all day, some of us. So one marker that predicts longevity more than anything else is VO2 max. Has anyone heard of VO2 max? So it's the maximum, it's the maximum ability of the body to extract oxygen during high intensity workouts. And you can measure that, so it's a reflection of your heart, your lungs, your muscles, just your whole cardiovascular system. And you can measure this in a lab with a mask. It's your Apple Watch or your iPhone will give you some crude measurements of VO2 max as well when you're walking or running. But VO2 max is one of the strongest predictors of longevity. And VO2 max starts to drop as we get older. So if you look here and you look at the green, who are the elite athletes, and then further down, people that have lower VO2 max, as you get older, you're able to do less and less things. And so, as we get older, our VO2 max goes down very quickly. So it's really important to start working on cardio now to strive to get up there. Nobody needs to be necessarily an elite athlete, but paying attention to cardio and not only doing sort of a foundation of regular exercise of cardio, but also having bursts of high intensity exercise, mixed in there is really, really important. So I would say that the rule of thumb is sort of 80-20. So 80% should be what we call zone 2 training, and 20% should be high intensity training. So zone 2 is sort of that all-day pace. You can have a conversation, and you can do that for hours. That's kind of your zone 2, whether it's walking, jogging, on the bike, the elliptical, that's zone 2, and that's 80% of your cardio, and 20% should be a little bit more high intensity. Believe it or not, another marker for longevity is grip strength. Remember we talked about turning and opening a jar? So there's a way you can actually measure your grip strength, and you've seen those things that people used to have to improve your grip. But it's not just about using that tool to improve your grip that's going to make you live longer. Grip strength is kind of a biomarker for aging, for muscle mass, for strength, for a lot of other things. So we know that people that have a good grip strength, as measured by this, is a sign of wellness, in a sense, in line of muscle mass strength. So VO2 max and grip strength are super important. How much time do I have?
5 minutes.
Okay, thank you. So I'm not going to dive too these are some of the drugs. You've heard about statins. I'm not going to get into that. I'm going to talk about statins overall, but there's a whole bunch of them we have out there. People worry about statins. Whoa, so statins have been around for 30 years to lower cholesterol, but to also improve survival from heart attacks, prevent strokes, tons of good evidence. But there's also a lot of noise out there that people say, oh my God, statins cause me to have dementia or do this and do that. And the answer is there's a lot of noise out there. And so I think they're fairly low risk. They can cause problems. In 10 to 15% of patients, they can cause joint or muscle pain. Rarely do they cause muscle inflammation that can be serious. Liver issues are very rare. There is a real risk of enhanced diabetes, but it's usually patients that are on their way to develop that it just accelerates that. So my strategy is to use very low dose statins, and I don't increase the dose because all the side effects, the muscle and joint aches particularly, are dose dependent. I use rosuvastatin or Crestor mostly. Then I add on other therapies like Zetia or Ezetimibe, and we have Nexletol, and now we have these injectable drugs that you may have heard of, Repatha and Leqvio, that do really amazing things in terms of lowering cholesterol. So I start with a low-dose statin, and then if I need to get the numbers lower, I add other drugs. And of course, the foundation, is food. I won't get into the mechanism of this, but this is the key here, right? That there's still work to be done, that heart disease, ASCVD, remains the #1 killer of men and women in the United States. But the thing is if we could treat this aggressively and earlier, we could potentially obliterate this disease. If we get there early while that soft plaque is accumulating in someone that's in their 30s and 40s, particularly if we know that there's some genetics in play, they're going to be at risk, then treating them early, and of course the foundation is food, but some may be drugs. ApoB is the best target for treatment, so remember that. Talk to your doctor. The goal is less than 60 if you have ASCVD. Lp(a) should be measured 1 time, but don't forget that other risk factors need to be treated aggressively. If your blood pressure is high, if you've got any tendency towards insulin resistance, prediabetes. To this audience, I don't need to talk about smoking because it's really not an issue. And then the biggest thing is that exercise may be the most powerful force to extend health span and longevity, particularly when we think about 2 measures, VO2 max and grip strength. And nutrition, sleep, and emotional well-being, play foundational roles. So, my job is to kind of deal with the whole person when I see them, and we talk about all these things, but then drugs are often necessary to fine-tune the care. So I really think about exercise and living and all the things that we're doing that should be doing now is really training for life. I'm not training for a race, I'm just training for life. And so with that, thank you very much. And I'm glad I have these slides. Thank you, Christy. Otherwise, I could have done it, certainly, but it's nice to have a few pictures. So.